because I'll not be using the mic. So thank you very much. Ames, let us go and dive into the ASD, VSD and ABSD. So what you have is, it ain't what you don't know that gets you into the trouble. It's what you know for sure that just ain't so, by Mark Twain. So that's what is there, and with this we start off with the ASD, atrial septal defect. So what is atrial septal defect? Basically, atrial septal defect is an opening of the atrial septum leading to a communication between both the left and the right atrium which has been there. So what are the incidence of ASD in postnatal is high, while antenatally detection of the ASD is very difficult. I have not seen many of the cases what we have done. So development of the atrial septum. My work has been already been made very easy by Dr. Mansi ma'am. So how does the atrial septum has been there? There is a septum primum which forms in there. May I have the mouse? So we have the septum primum which is growing here, and this is the endocardial cushion which forms the septum intermedium. So from up it comes to the septum primum, from below the septum intermedium starts to grow in that, and then there's an opening which form. This is a primum ostium which has been formed. Once this has been formed fully, so if you see, this is the septum primum which has been forming. From below the septum intermedium is getting, and then when it has been fully formed, there is a fenestration or apoptosis which occurs in the proximal portion of the septum primum. This is very much required, and this the later fuses in this one. At the same time, there is a septum secundum which is growing towards from the right side of the septum primum which has been there. This is an incomplete growth. It does not join properly. This does not join properly. This does not meet each other. And why is it so? Why is the formation of this one? It's for the formation of the foramen flap of the foramen ovale which has been there. So it has only one-way movement which has been there, from the right atrium to the left atrium which has been there. And it forms like a wall kind of a thing, like a tricuspid wall or a well. It's just one-way gate which has been there. If there is an increased pressure which has been there on the left side, this will approximate and it will get closed in this one. Until and unless there is a severe distortion of the anatomy, or there is a HLHS, hypoplastic left heart syndrome. In those cases, there will be a reversal of this foramen ovale flap which has been there. But until then, there will be only a one-way flow from the right atrium to the left atrium. And why do we need that flow which has been there? As has been brought, the DV carries the oxygenated blood, preferential blood which has been there. Via the aspiration tube, it goes and it comes around and it hits around this foramen ovale. The direction of that, the anatomy is such a beautiful thing. The anatomy is there, it goes directly, preferentially grows into the foramen ovale and gives the oxygenated blood to our brain, which is the most requirement is there. And that's the function of your whole of your DV, ductus venosus, which will be dealt by Alpesh sir later on. So we have all these kinds of defects which can be there. There can be a septum primum ASD, the septum secundum which has been there. There's a sinus venosus and a coronary sinus defect which was there. So we'll go one by one. This is the same layout. We have already dealt with this one. So, sorry. Septum secundum defect is the most common defect which has been due to lack of tissue in the region of foramen ovale as the most common, accounting for approximately 80% of all the ASDs which has been there. But this is very less likely to be diagnosed in there, because most of the ASD, whatever is there, it is not very much diagnosed prenatally. But that what is more important to us is this septum primum defect which may be detected there. So septum primum defect is the second most common and presents a gap, as you can see here clearly. So this is the septum primum region which has been there. See, when the anatomy comes around there, this is the region where the septum primum was going on from this. And if there is a defect in this one, this is called the ASD or septum primum defect, which is a part of a partial atrioventricular septal defect which has been there. So this may be a little bit of, maybe you may find this kind of artifact may be there because of artificial, or it may be an pathological in this, or maybe this is there because of something else which is called a persistent left superior vena cava. So we will deal with this one and how to differentiate this one. So ASD can be identified in the fetus by visualizing a gap in the septum primum region. Here you can see that gap which has been there, and you can see this. So if you look at this, this is a case of a VSD, but if you look at this region which is there, has been brought by, ma'am, the coronary sinus. This is the coronary sinus, because what you are getting is, when you are toggling from, as ma'am said, from abdomen, everything, the echo starts from abdomen. So when you are toggling yourself from the abdomen, stomach, going up, taking up a little bit of view at the level of your diaphragm where the USG beams are cutting, there you can see, you find that there is a linear insertion of the or both the walls which have been there. But it is not there. It is just where your anatomical position it is there. It is not a linear insertion. It is not a AVSD, but it's the position. And here you can see the coronary sinus. So you don't have to misjudge or misdiagnose this as a ASD or a septum primum defect. Once you will come more ahead, chordally which has been there, there you can see the septum primum which has been there. If you don't find, only then you have to say that it is a septum primum defect in this. So as it has been brought, and it will be brought where the tricuspid wall has a more apical insertion, and there is an offset which has been there. If you find a linear insertion, then you suspect this septum primum defect, because during that time both the walls, which are, the tricuspid is a little bit lower and the mitral is up. So there is an offset which has been there. If that offset has been lost and they have a linear insertion, there you can suspect this kind of a septum primum defect which will be there. So this is the case. As you can see, this region where we have there, we don't have that septum primum, which the crux, echogenic material, the thing which was been present, it is not there, and this is the septum primum defect which is there. This is the lateral section. So you have an apical view and a lateral view. If you have any section, as in radiology it has been there, you always need to confirm your finding in two sections which have been there. So you take that, you take a lateral view, chamber view, and here in the lateral chamber view you can clearly see this is a septum primum defect which has been present in that. So you confirm in the another section which has been there. The same way, the septum primum defect which has been present. So how? This is one grayscale. How will we have other tools also? And we should use this. And you should use more often. More you use it, more you will get accustomed. And the most powerful part, and your basically this your parachute which has been there, is your color. If you have an obese patient or somewhere like that, you use your color, you will be able to get it more better. So in the same way, this. So where is the septum primum ASD? If there will be a defect, the flow will come from the right atrium to the left atrium which has been there. So you have an indicator. It does not mean it will be blue or red which has been there. You have a toggle where on your right side of your machine where it will be there, you will have a red or a blue thing which has been there. Whatever is your setting which has been there, if it is towards whatever is there, it will be your whatever color, it may be a red color. It is, if you do it invert, it may be a blue color. But you need to see that section, and you will find that the flow is coming from the right atrium to the left atrium in case of a septum primum defect. But if you have a coronary sinus which has been there, because dilated coronary sinus, because of a persistent left superior vena cava, the flow will come from left atrium to your right atrium which will be there. So you got my point in this one? So this is how you have to differentiate between the septum primum and a different DD which has been there. So this is a PLSVC which has been there, and the flow is coming from the left atrium to your right atrium which has been there. So there is also one more thing, a sinus venous defect which has been there. It is difficult to image there. The typical appearance could be an opening at the site of connection at the superior and inferior vena cava. So you have this superior vena cava which is inserting inside which is draining into the right atrium. You have an interatrial septum which has been present. So you don't find anything which has been offset which is in there. There is no overriding. Anything which is defect will be there. There might be a little bit of overriding, as you can see in case of this sinus venosus ASD where will be there. So where all you can suspect this one is, it is very difficult to find these kind of sinus venous defect. But there is an association. These sinus venous ASDs are more common, 80% more common in case of a partial anomalous pulmonary venous connection, PAPVC. So if you find a case of a PAPVC, you go retrograde and you look for a sinus venous ASD initially. And then afterwards, once you have accustomed yourself to see this one, then afterwards, hopefully, you will be able to, if you get a case, you will be able to detect a sinus venous ASD which has been there. So what are the associations which have been there of the ASDs which has been there? It may be associated with the isomerism, abnormal PAV, pulmonary venous connection, or a single ventricle. These are all theoretical portion. We will not go much into that. You all can read all about this one. So we have the about 10 to 15% of all the ASD2 which has been there is associated with the abnormality of venous system which has been there. 80 to 90%, as I have already told, superior sinus venous superior vena cava is associated with the PAPVC which has been there. So if there is a ASD type 1, it's a type of a atrioventricular septal defect. So your association was with the AVSD, there is an association for your trisomy 21 or Down syndrome which has been there. If you find an ASD, atrioventricular septal defect, and if you find a double bubble, you can be very sure, almost up to the 100%, that that baby will be a Down syndrome baby which has been there. If you have a septum primum defect which will be there will be a 12.5% association or risk with for a trisomy 21. So you need to investigate that one. You need to go for an invasive testing to confirm the same thing, and then afterwards you need to guide them. As been told, a multidisciplinary team has to be there. You have to make that counseling with the pediatric cardiologist. He will be able to make them understand. You also make them understand. Two doctors retreating the same point makes into feel of the patient that yes, these both are saying the right thing, because still tonight and today in this era of our India, the doctors are being considered as if they are somewhere, they want to harm you. So you need to be on side. You need that one guy and the other guy to substantiate you. So the other one is saying the same thing, then you are also medically right also, and the patient also trusts you more in that way. So once you an ASD is suspected, you have to find further. So if you find any, this is for everything. If you find one abnormality, you have to thoroughly check around there whether there is some abnormality. It is just like doing a car check was there. If you find some एक आवाज जहाँ से आ रही है तो आपको पूरी गाड़ी को देखना है कि कहाँ से कहाँ आ रहा. That's the same thing which you have to do. If you find one abnormality, you look around all the anatomy, all the structures which has been there, and you look for any associated. Then only you will be able to find out these genetic syndromes which have been there. Just not by one cardiac abnormality, but you have to see for the other association, and then you will be able to find out. We have already dealt with the false positive diagnosis of the septum primum with the dilated coronary sinus, which will be there in case of a persistent left superior vena cava. So it's the same thing. Now what happens is, sometimes a dilated foramen ovale flap has been brought back. It may gives you an appearance that there is a septum primum defect is there, or maybe an atrioventricular septal defect which has been there. But this is not the case which has been there. If you look, this is the small left ventricle which has been there, and here you can see the foramen ovale flap, which is a redundant foramen ovale flap which has been aneurysmally dilated, and it is hitting almost up to the left atrium which has been there. And because of this, the foramen ovale flap, aneurysmal dilatation, it is giving you a picture of a septum primum defect. And it is also causing one more thing. From the right atrium to the left ventricle, the flow has to go. But this is getting obstructed because of this foramen ovale flap which has been there. So your left ventricle is appearing smaller, and it is giving you a pseudo coarctation of aorta feeling. This patient came to us as a coarctation of aorta. We told that this is not a coarctation of aorta, it is a pseudo coarctation of aorta because of the aneurysmal dilatation of the foramen ovale flap. You can see the shell sign also, which is present there. You can see this one shell sign, but these are all pseudo. It is why? Because the left ventricle itself is not getting a lot of amount of blood, which is supposed to get from your pulmonary veins, from the left atrium, then into the left ventricle which has been there. Because of this flap which has been there, less amount of blood is going. If less amount of blood is going to the left ventricle, less amount of blood will go to the aorta. If less amount of blood is going to the aorta, the narrow aortic arch will be there. It will become narrow in that way. So what has to be done is this. No treatment is required in this one. You just tell them that foramen ovale flap will close postnatally. it without any medication. Which actually you don't need to continue those medications. You have to stop those ones, and it will close this. As soon as this foramen ovale flap will close, your flow from the left atrium to the left ventricle will be all good, and the baby will be all right without any problem with it there. So this may also give you a false DD of a septum primum defect. So this is basically something. You see a kind of a Harry Potter sign there within the baby. Can you see this one? But this is not there. It's a pseudo kind of thing, which is it is just been made up in that. So you have to see what is hidden beneath this abnormality and look out in that. So this is basically a pseudo coarctation of aorta because of the redundant foramen ovale flap which was been there. Can you see this one? This is the flap which has been there, giving you a picture of a septum primum defect which has been present. Consult the patient, and the baby is almost is doing absolutely fine. I think so. The baby, they had a baby girl, and it's around 3 years of age. So you have to conservatively follow. Now coming on to the ventricular septal defect which has been there. This is the most common cardiac abnormality which has been there, but it also has a false positive rate which has been there. And most of the time you may find it or not find it in there. So this is the opening in the ventricular system leading to the hemodynamic connection between the left and the right ventricle which has been there. So before diving into a little bit of embryology for our understanding in this. So what happens, it is there, the bulbous cordis has been formed, there is a primitive ventricle, there is a primitive atria which has been there, and a sinus venosus. So this is the atrial end, this is the venous end, which will be dealt in very detail with Dr. Alpesh sir. So the bulbous cordis is divided in three equal portions. The uppermost part, which is called the truncus arteriosus, the middle portion is called the conus, and the one which is proximal to the primitive ventricle does not have any name, but this is there. So you have a bulbo-ventricular, a sulcus which has been present in this one. So what happens, as been told by ma'am, by the D looping and the L looping which has been there. So embryologically what happens, initially they form a tube, then this atria moves this and in form a D loop which has been there, and the atria moves forward and comes here. And this is my primitive atria, this is my primitive ventricle. So between the atria and the ventricle, here in this region, the endocardial cushion develops in this one. And this endocardial cushion is responsible for forming your both the tricuspid wall and the mitral wall which has been there, both being separated from the right and the left side which has been there. Since it is my topic which has been to be discussed on the right, that's why I thought a little bit of embryology is better. So what happens in this one, this interventricular septum which has been formed, it is not formed by a single structure which has been there. It is formed by three structures actually which has been there. So what happens in this endocardial cushion which is there, this is the interventricular foramen which forms in this one. And this endocardial cushion, the cells proliferate within this one and forms a membranous part of the interventricular septum which is there. This septum which you are finding in this, it is not a 2D dimensional structure, it is a 3D dimensional structure which has been there. So this forms the membranous part. So this portion which has been there, bulboventricular sulcus, in this region which forms, this forms the muscular part of the interventricular septum which has been formed. So this is forming a muscular part, this is forming a membranous part, and the bulbous cordis also takes a growth downwards and forms a little bit of the membranous part of the interventricular septum. So you have 2-3 openings which have been there. So you have an interatrial opening between the right and left atrium. This is the interatrial septum which has been present. You have an opening between the between both the atria and ventricular, which is called the interventricular septum which has been there. But did you know that there is one more opening which has been there, which is present between the right atrium and your left ventricle? There is also one more. This is what is the opening which has been present, and that's called is formed there, atrioventricular septum which has been present there. This has been formed, and sometimes when you have the VSD and all the flow which has been there this defect has been there, and there you can find out. So we will deal with all the abnormalities there, but there's also one more opening between the right atrium and the left ventricle because of the atrioventricular septum which has been present. So once we have dealt with this one, and we form the muscular portion and the membranous portion of the interventricular septum which has been there. Now this is the same which has been retreated. So The incidence, as has been told, this is the most common cardiac congenital heart defect which has been formed. It accounts for around 30% of the child born, and are also associated with other cardiac abnormality. There are obligatory and there are maybe other VSDs which are there, will formed. So we have an inlet septum, we have an outlet septum, we have a membranous septum which has been there, and a thick trabecular muscular septum which is there. Thank you. So nice of you. So these are the VSD. Let us go deal one by one which has been there. A VSD can be detected. Actually now, the VSDs can be detected even in the first trimester. With the expert like Alpesh sir and the other, as you, the future experts, you are there, you will be able to detect these cardiac abnormality as early during the NT scan also, or maybe much before than in this. All you have to do, before you drive a car, initially when you are driving a car, you feel a little hesitant in that. But once you are accustomed to that, you start driving it, then you don't even think whether you are putting a first gear, second gear, third gear or somewhere like that. It will come automatically to you. What you need to give is, you need to practice every day. Practice on normal. Then you will be able to find there is something abnormal, a miss which will be there. The same thing, so these defects which may be there. So how do you detect these ventricular septal defect? And how do you differentiate from the other which was been there? So you can find there, so we have these types of perimembranous VSD which accounts for the 7 to 80%. Let us not go for the theory. I'll show you all this thing in the image only. So you have this inlet VSD which has been there, which is just present below the atrium and the ventricle which is there. You have a muscular VSD which has been present, and as you go and open the LVOT view which has been there, or your 5-chamber view which has been there, if you find a defect there which is present below the conus, there is something which is defect may be present above the conus. That is normal. Once you go and you find a 5-chamber view which has been there, which will be, you open up the LVOT, you will find most of the time you have a defect which has been there. But that defect is because of the coronary sinus. I'll demonstrate that the same thing. If you find that below the wall, below your aortic wall, that is your perimembranous VSD. Above is normal. Below, if you are finding, it is abnormal. And then afterwards, you have to see whether there is an overriding of aorta or whether it is just an isolated perimembranous VSD. All things will be dealt. So you have an inlet VSD, you have a muscular VSD, and here you can see a perimembranous VSD. We'll get you more in this one. So you have an aortic wall which has been there, and this defect is formed here. So most of time, what you'll find, aortic wall is there and there is a defect here. In this upper, above the aortic wall, you can find these movements of the aortic wall if you are taking the sections properly. And if you find a defect above, that is because of the coronary sinus and not because of a perimembranous VSD which will be there. So inlet VSD are found in the region of the AV wall in the 4-chamber plane and are often difficult to differentiate from the mild form of complete and partial VSD which have been there. But once you keep on seeing, that is not. But this can also be an insonation defect which will be there. Because your USG beams are falling perpendicular there, you may find a dropout artifact in this one. So what you need to do, if you find a apical chamber view and you are suspecting an inlet VSD, you toggle and make it in a lateral side to confirm whether the defect is there. If you find the defect there, then only you call it as an inlet VSD, otherwise not. And the second thing, this is on the grayscale. Then what you have your, basically your parachute, your color Doppler parameters which you are using less and less is the one thing which is the parachute which has been there. You put the flow and you will be able to find the defect. There is a flow which will be going from left to right and right to left which has been there. It's a bidirectional flow which will be there. This is the same thing which we have been tooling. The lateral chamber has to be taken in reducing the false positive wave. So here you can see the 5-chamber view which has been there. It has been already told by ma'am, mitral aortic continuity and septo-aortic continuity which has been there. If there is a defect in this one, then you suspect this as a case of perimembranous VSD, but it may be normal sometimes also, because, and nothing is to be made on a still images. If somebody gives you a still images and tell you what is the diagnosis, it is not to be made. It's always in the cine loop is where you have to make it in. This is the same example of the inlet VSD which has been there. And you can see the flow also. The flow which is coming around here, you can see beautifully that this is the true defect and true inlet VSD which has been present there. You can measure this inlet VSD, you can put the color, all this. So that's the inlet VSD with the color which is there. So you have a muscular VSD, and most commonly these apical portion of the muscular VSDs are the most commonly missed out. What we find is I am not able to find any VSD which has been there, or you may have a apical chamber view which has been there, and then you may have a dropout artifact. You can see in grayscale also if you are looking, and we will give you a little bit of demo during the live section. You can see that there is maybe a defect which has been there. So you have a defect. How you will see know that it is a true defect which has been there? There will be echogenic areas which has been there. I'll show you. Borders will be echogenic which will be there, and to and fro flow will be there between. See, there is a difference in the chamber in the left and right ventricle which is there. Sometimes this chamber will have a right ventricle will have a more pressure, this will have a less pressure. So they will have a bidirectional flow which will be there. And if you demonstrate that bidirectional flow with the help of your spectral Doppler, you have confirmed your diagnosis of a VSD. So if you find a VSD in your grayscale, put the color, and then afterwards put spectral. You go one more ahead in that, one more safety net which is there, and then you confirm whether the to and fro flow is there. So you have that bidirectional flow here. You can see red, blue, which has been there. So you know that this is the ventricular septal defect which has been there. And then afterwards you find the spectral, and you find the bidirectional stunting. This above going and below going, above, below, above, below. So it's the flow which is going to and fro which has been there. So you see this one. This is a case of a VSD, a huge VSD. You can see the echogenic tip there. This is your marker that is a true pathological VSD, and it is not a dropout artifact which has been there. In this case, you don't even need to put colors and everything, because in the grayscale itself it is there. But we need to, for our completion's sake, we need to put the color, and you can see the to and fro flow which has been there. And then afterwards, if you have the stick and this thing, you can just demonstrate the VSD which has been there. The majority of the VSD, what you have to tell them is if there is a VSD or a there is an associated chromosomal abnormality of that. So you have a perimembranous VSD, is the most common VSD detected on grayscale ultrasound and visualized in the 5-chamber view which has been there. So we will just look at this one. So here you can see this is the wall which has been there, and the defect is below the aortic wall which has been there. It is not above the aortic wall. If it is above the aortic wall, it is the normal conus which has been there, and it is normal. It is not a perimembranous VSD. So what you have to see where the wall is there and where the defect is there. So you will find out this is a perimembranous VSD. So a demo of the same thing. So this is the perimembranous VSD, and along with that there is an overriding of the aorta which is there. So this becomes a case of a tetralogy of the fillet which has been there with the perimembranous VSD which is there. Then another case of a perimembranous VSD. So when it has to be considered, whether it is small, you may find the perimembranous VSD may be isolated also without any overriding. So you need to follow these kind of patients which has been there. And if it is a perimembranous VSD or a muscular VSD in that, this usually, if it is a smaller, it usually closes by second year of life in that way. You just need to follow this up. Probably during the neonatal period also, sometimes it gets closes, mostly the muscular. But the perimembranous may close by the second year of your life which has been there. And if it is not closing, then you have to intervene there. There is the outlet VSD. Unfortunately, I don't have much cases of the outlet VSD. So these are all the things which we have been telling around there, how to differentiate between them. So there are obligatory associations in this one. You can just take a click in this one. You don't need to mug up everything. Everything is there. Once you diagnose a thing and a condition, then afterwards you can take a support and what are associated findings, and then afterwards you can look at that. First thing is diagnosing. First thing is finding an abnormality. Rest all that theoretical portion can be taken and dealt with. As you learn from the cases, you will be able to know about this thing. There's the extra cardiac association. Trisomy 21 needs to be ruled out in this one. Any case which is there, you need to rule out other cardiac abnormalities. You need to rule out other structural abnormalities when you have ruled out everything and you just see a VSD which has been there, this may be most common and it does not require much of them. But until and unless, how will we become fetal medicine specialist or somewhere like that? So we offer a little bit of invasive testing, and it is always better. It is always better to be more on side, more on the testing side than to because that error which will be there, it will cost that parents their whole life. Once a case of a Down syndrome has been diagnosed, once the patient has been got, ask that parent, will you again do that? I have seen the Down syndrome patient babies coming again, absolutely normal, but they want 100% sure that they don't want this Down syndrome baby. So it is all good. As I tell you about that thing, we are all speeding in our bikes and our cycles. Till we get an accident, we will not be very careful. So we should not do like that, and you should always investigate whatever has been there, and you should offer medical legally also and as a doctor also. And it does not mean that every patient you are making them anxiety, because most of that thing, even if a small EIF, they think that is a it's a heart mein chhed hai, VSD it is there, and they go for termination. I have seen that. I have seen that. So we have to explain the counseling part is the most important part. So first you diagnose, learn, and then you go for a counseling part, which is the most important. So you have an atrioventricular septal defect which has been there. Please stop me if I'm overshooting. I've already overshooted. Okay. I'll just take a little bit of time. Atrioventricular septal defect which has been there. So as it has been there, it is a defect both in the atria and the ventricle. So it is a septum primum defect with the inlet defect which has been there, which is the atrioventricular septal defects which has been there. The incidence are all are 4 to 7.5% cases which has been there. There can be a complete AVSD or a partial AVSD. If there is a complete AVSD, partial is your septum primum defect which has been there. That has already been known. If it is a complete, it is maybe a balanced or unbalanced. Basically, both the vessels are both the ventricles are balanced. Both of them are looking normal or abnormal. If there is abnormal, then it is an unbalanced. But the challenge happens in the unbalanced is in the diagnosis of the AVSD. You may find that it may be some other abnormality which may be there, but it may be a AVSD. So your sections has to be very clear in that. They have a common atrium, the pipe lifted, there's the absence of crux. We will go for the cases which has been there. A lot of AVSD cases which will be there, which will be dead in the NT scan. So I will pick up those cases during that time. I knew that I have to take a little bit of time in this one, so I was well prepared, and during that time, I will get you back on the atrioventricular septal defect and little bit of chunk. So we have the balanced AVSD, where both the ventricles are of a normal size. Unbalanced, one of them is the hypoplastic, and it may, in certain cases of unbalanced AVSD, you may not be able to find the right ventricle. You may think that it is just like a single or a mono ventricle which has been there. But you have to look at the scans, you have to look at the image properly, and then afterwards you can find it there. So you have already, we have already discussed, if there is a linear insertion of both the tricuspid and aortic wall, there is a septum primum defect which may be there. So it is a part, where your sensors should be there. As soon as you see the linear insertion, okay, this may be pathological and I need to see it carefully. Then afterwards it may be a partial AVSD or a complete AVSD. So what you need to do in this one is you need take a clip and then just stop it. And then afterwards, during the diastole and the systole, you will find whether that opening and there's a complete opening which has been there, and there you can see the complete defect which has been there. See, already been told that in diastole the common wall is open. You find a huge defect both at the region of the septum primum and the so here you can see. Can you look at this one? This is a huge defect which has been there. Okay. So this is the atrioventricular septal defect. As I told you, if you find one case, you look further. This baby also had a post-axial polydactyly which was been present there. Unfortunately, we had this baby's earlier pregnancy, the sibling which was been there, they had both pre-axial and post-axial polydactyly which has been there. They terminated this pregnancy just because of AVSD, and also they were from a poor social economic background which is there, and they didn't want to have a child with the AVSD which has been there. Though we had counseled them that you need to rule out this one, and it carries a relatively good progress because the pediatric surgeons are doing excellent work, but they didn't want it to continue. but unfortunately they had to go for this one. So in systole, what you see, the linear insertion which will be there. Both the walls which are the tricuspid and the and mitral wall, both at the same level which will be there. That's it. Same partial AVSD we have discussed. And then the color flow, Doppler, we will find the flow which has been there. We have both the inlet VSD which has been there and the septum defect which has been there. So you can see both the left ventricle and the right ventricle, they have a communication which has been there. I'm just finished with this one. No. I understood with just by the. These are associated cardiac abnormalities are all the top DRV which will be dealing. There is an association of the coarctation of aorta in case of partial AVSD which is there, septum primum defect. Extra cardiac abnormality, you have to look for each and everything which has been there. Trisomies, you need to rule out in case of AVSD. This is the most common association. Non-chromosomal may be a cardiosplenic or a chondroectodermal dysplasia which may be present there. And there may be a short rib polydactyly or all the other things are there. You name a thing and then afterwards you can find all these diagnoses which has been present in this one. It is not getting over. Oh, I just wanted to. I'm finished. Cancel. Napping and yawning, I think. Thank you.